Hello, hello, hello. This is Tooth Be Told, Dr. Kyo Dumpert.
Dr. Walter Aka.
Hey, my name is Leroy Horton.
And we were very excited because Dr. Horton is a board certified implantologist, and when it comes to dentistry, there's so many different avenues you can go. Right? There's so many different ways you can learn. You can learn ortho, you can learn all this other stuff, and I think the beauty about being a general dentist is you can. There's no limit to what you can learn, and there's no limit to what you can do. And that's the best part. Some people look at it and go, "Oh, that's the most frustrating part." But I don't. I actually think being a great general dentist involves continue to learn.
Absolutely.
And you being board certified shows that you actually had the respect and the intelligence, to want to get to that level of excellence when it comes to implantology, surgery of different types, soft tissue, hard tissue, so forth. And so
Correct.
I wanted to get you on here. And we have something in common. We both were on the Howard Ferrand show, and we were just talking about this before we started recording. That Howard basically goes on his own little tangent. But we love
Correct.
him.
Yeah.
But he definitely. I don't even know what some of the questions were. Kyle, I'm not sure if you remember any of the questions, but it was Howard talking to us. It was Howard talking to us.
Right. I tell you this, Howard almost set me up. So one of the things I do here locally is I teach a lot of PRF courses because it's been a heavy component of my practice. So he sets up this question by saying, the great Carl Misch said that, PRF is a bunch of voodoo. What say you? like I'm gonna jump into a posthumous debate with the great Carl Misch.
Okay. So for people that don't know, Carl Misch is like the guy who made implant and implant education, open to everybody else, right? He's that guy. He's basically, there's a father of dentistry, restorative, an amalgam, right? We got GV Black. He's that guy that everybody, when you talk about restorative, you talk about GV Black. When you talk about implants, you have to start with the basics, which is Carl Misch and his book. So everybody learns this. I don't care if you're a specialist, a general dentist, whoever. You have to learn Carl Misch. So there's no way you're gonna win this discussion.
No.
None. Like he set you up for failure, 100%. You know what I mean?
No. So I reframed it. When he was like partway through that question, I kind of understood what I had to do because I'm not going to be that asshole that's taking on Carl Misch from the grave.
Right. You would lose completely. This being the cancel culture, you'd have been canceled.
Right.
We wouldn't even be talking to you right now.
Absolutely. But I was able to reframe it as kind of a philosophical debate between kind of the common sense use of that particular treatment protocol and some of the outlandish claims that some of the groups out there are making that it can do. And basically just said that it's an adjunct to good, sound surgical protocol. But the setup was real. I mean, that could have gone left and killed my entire, reputation together. But yeah.
Well, let's kind of get a background, I guess, right?
Yeah. Let's tell us about yourself and how you got to where you're at.
All right, so I'm gonna speed through it. So I'm originally a transplant. I immigrated from Greece when I was a teenager. Me, my mom, and my brother. I had some exposure to dentistry because my aunt in Greece was a dentist, and my uncle was a cardiologist. So I knew I wanted to get into healthcare, and I thought it was going to be medicine. Shoot to like second or third year of college, and one of our instructors, who was really big at exposing us to what you can do with a degree in biology other than med school, because she wanted to be practical and say, hey, some of you might change your mind, some of you might not get in or take a gap year and find a completely different direction. So we did this self-assessment of where do you want to be 5, 10, 15 years and so forth, and you answered all these questions, and then he matched you up with careers in healthcare that match those answers that you gave. And some of them were like, how much autonomy do you want, how much family time, how much responsibility, and so forth. And dentistry was ranked one of the highest. And I've always been a big proponent on, if you're going to make a decision, make a well-informed decision, thoroughly study it, especially if you're at the point where you're choosing to commit the next 8 years of your life, or
Mm-hmm.
hundreds of thousands of dollars, like, do your due diligence, right? If you come back to the original thing that you wanted, great. That means you've vetted it and really compared it to everything else out there. You could trust that decision. Or if you change your mind, then it's an honest decision to change your mind. So I created this independent study course that Pacific Lutheran University, where I went to, had you could create a 1 credit college course called whatever you want. It's an independent study course with an advisor. So I created it. It was just called the Different Fields of Dentistry. And my assignment was to go to my general dentist. He put me in contact with all the specialists he refers to. I shadowed each one for 2 or 3 days and wrote a report on each field of dentistry. And when I shadowed both the oral surgeon and the periodontist, it was like I had an aha moment, right? Like just that light bulb went off. And I was like, I want to do surgery in and around the mouth. Like, that's what I want to do. And it's been around since then, so there was no doubt, no, second guessing of what I wanted to do. I wanted to go to dentistry. But then it was, do I try to do a residency? Or, because by the time I graduated, I had 3 kids. My mom had taken on a lot of debt unbeknownst to me to help put me through college, buying books and all that kind of stuff. And my brother was getting to that age where he was about to start college, and I didn't want her to incur more debt. So I just said, let me just work as a GP, and I can just really tailor my continuing education and my training and my practice to some of the surgical procedures. And that just kind of led me on that path to really diving deep into implants, slowly, and methodically growing my skill set to the point where that's just a large portion of my practice now.
Are you
So
still doing any general dentistry at all?
I have to by default, because I'm partnered in 2 offices and we have full-time associates. And so I end up doing the stuff that they don't feel comfortable with. And there's a handful of patients that just only want to see me. So every now and then, I'll do their hygiene checks. I might do a filling here or there, a root canal that my associates don't feel comfortable, like second molars and so forth. But I would say 80% of what I do is either implant related or wisdom tooth related.
Okay.
Well, let me start off by saying I don't know how you did it with 3 kids and go through dental school. That's amazing. Right there, you should win an award. I can't do it with 2, and I've been out of school for a while. So I don't know how you did that. You got more. That's amazing.
I can't take credit for that, man. I'd love to take the gold medal for that, but unfortunately, or fortunately, I had a very supportive wife that made sure that I had time for studies and stuff. I had my mom lived 5 minutes away, my mother-in-law another 5 minutes away, and so I just had an amazing support system to be able to do what I wanted to do. And without that, it would have been a struggle for sure.
That's awesome. That's awesome. But let me ask you this. So you just said that you do 80% of it is the surgical stuff, the stuff that you want to do, right? And that seems to be like the golden area. Like a lot of general dentists, a lot of people want to do just the things that they really enjoy, right? Like, for example, the reason I went to perio was because I hated dentures. Now, if I would have eliminated dentures, I might have actually been a general dentist still, because I loved everything else. I hated dentures, but loved everything else, right? And so then the question is, how long did it take you to get to this point? I want to know how did you get to this point, and how long did it take you to get to this point?
Well, it took a number of years initially, because you only have your patient pool to draw from, right? And you're only doing the cases you're comfortable doing. So of all the possible cases you have, you're only doing, a small percentage of them in the beginning. And as your experience grows, as your ability to describe and educate the patients on what they need, why they need it, your confidence and your ability to sell the treatment grows. I was lucky in that my employer, who later became my business partner, he's older than me. He's in his 60s, and he'd been placing implants for years. So I had an on-site mentor that did that stuff, who I was able to watch do it, dozens of times. Had him over my shoulder my first couple times. and then we were both CE junkies, so we were always taking, whether it was classes at the Zimmer Institute or, just any implant convention or AAID, ICOI, all that kind of stuff. So my dedication was to continued learning, but it's such a slow crawl at first because you don't want to put your patients at risk by being a cowboy, right? And doing stuff you shouldn't be doing. And I took that seriously because there's a lot of doctors out there that will just, all they're looking at is there's an empty space. I'm not sure if there's enough bone or not, but there's a tooth missing. So we're doing an implant. They're not looking at occlusion, general health, the general perio health. Are there other more pressing needs? Is there even restorative space? Like they're so myopic in how they view what they're trying to do. And I know I didn't want to do that. And so it probably took about 5 years before I really, really got comfortable. Because mind you, I'm trying to implement this in my day-to-day existing practice. So it took about 5 years, and at that point, I felt like I hit the ground running, and I really felt good about what I was doing.
And you said you're a board certified implantologist. Is that right?
Correct.
Did somebody? Okay, so is that for our listeners? Is implantologist? Is that a dental specialty? Like one of the special? Go ahead.
It depends on the state.
Okay.
So some states have recognized it. I think I'm in Washington State. Washington has been mulling it over. The dental board has been mulling that over for the last 2 or 3 years, whether they're going to recognize that as a specialty and what that means. Mm-hmm. So, I mean, I don't purport myself to be a specialist in, by any sense of the word. But I have dedicated a large part of my career and my practice to implants. And I'm very open about that to patients. But it is a sense, a specialty in how you view your dedication of your time and your how you carve out your day-to-day practice. Because to be good at it, you have to do it all the time. Right. The whole 10,000 hour thing, it's real. And when you think about it, when I thought about it, when I did the math on it, 10,000 hours in dentistry, when you're talking about how many days you work, 8-hour days, it's about 5 years. Mm-hmm. And it takes about 5 years of doing something consistently to be really, really good at it. And there's always room to grow and be better, right? Mm-hmm. But to be really, really good, I would say it takes about 5 years.
What's it take to become a board certified implantologist?
Well, that was more philosophically speaking, right? Okay. Technically, it still probably takes around that long because a lot of the cases you have to submit when you're going through the process, they have to have been placed and restored over 3 years ago with follow-up images. So there's no way to kind of do that on the fly anyway. You have to have been doing it for a number of years to have the number of cases. Because I think we had to initially submit 120 cases that were all over 3 years old. And then as you go up the ranks, you have to, you have to case present 20 cases through PowerPoint. They have to be of specific types. Some of them have to involve sinus augmentation. Some of them have to be full arch. So you have to get all that under your belt as a general dentist. You have to have been doing it for a long time by default.
And that's with what organization?
The International Congress of Oral Implantology, the ICOI.
Okay.
Yeah.
I always say, like, if you're gonna do something, like you said, you have to get in. You can't just can't half-ass anything, right? You have to just say, I'm gonna do it, right? And right. I find that a lot of people just kind of dip their toes in there and say, all I'm gonna do is this molar. I'm gonna do molar implants, right? Because there's so much space, and I'm gonna send that off, everything else off. Right. But how do you become proficient at something when you just only select? That's like saying that all I'm going to do when I play basketball is dunk. I can't see the reason. I'm just going to, every time it's going to dunk. And you're not Shaq, by the way. You're not Shaq.
Right.
Every single time, all you're going to do is dunk. Like, to me, it doesn't make any sense. You know what I mean? Right. And so for me, I'm like, what kind of changed your mindset to say, I'm going to just devote the time and the money? Because a lot of people don't realize that there's a financial aspect to it too, right? And so, like, what made you say, I'm going to devote the time and money to education and learning and becoming as good as you are?
Well, I don't like. This is one thing about me personality wise. I don't necessarily have to be the best at what I do, regardless of what I do, right? So
Okay.
when I was an amateur fighter, I wasn't consumed with being the best, but I wanted to be that upper echelon. You know what I mean? Like I
Mm-hmm.
want to be good to great. And I don't, being mediocre, there's like a complex or a fear that I have about being mediocre at anything, right? So somewhere, if I can be way better than mediocre, even if I'm not the best, I'm complacent in that.
Yeah.
And when I tackled implants, that's kind of where I wanted to be. I would take all these courses and read this literature, and I would aspire, to want to be as knowledgeable, as proficient, as competent as some of these high level practitioners that would be teaching these courses, because I wanted to belong in that group. So that's kind of a personality quirk of mine. And the other part of it is when you're doing surgery, you are doing semi-permanent stuff for people. Whether it works or whether it doesn't, it can be semi-permanent, right? And that's a huge responsibility to take on when someone is trusting you with their well-being, their health, their function, their aesthetics, their money. A lot of this stuff is expensive. Like I want to know, even because everyone has failures, right? I
Right.
want to know that every failure I've had, every case that didn't work out, was a hard-earned failure, meaning
Mhm.
it failed despite all my best efforts, right? It,
Mhm.
it wasn't a half-ass failure. It
Right.
wasn't a stroll in the park failure. It was a hard-earned failure. Um, and I think that's just something that it's either ingrained in you or it's not. Some people can do dentistry and be very disconnected from the affect that they have on people.
Hmm.
Whether you break a file in a root canal, and you're like, all right, this stuff happens, refer it out. And there's people that will lose sleep over that. Will take that L and say, all right, well, what did I do wrong? Let me
Right.
break this down. Let me reverse engineer what the hell I just did, because I don't want this to happen again. And I think that can be taught to some extent, but I think it's got to be who you are,
Yeah.
to have that constant desire to be great, if that makes sense.
Now, I'm going to throw Walter under the bus here a little bit, or
Please.
try to anyway.
Please.
Try to anyway.
Please.
So,
If you listen to previous podcasts, we had Dr. Dennis on here, and that was his job. So Kyle's taking over right now.
I like to stir the pot a little bit. So,
Okay.
couple of basic questions, Walter.
Yeah.
Roughly ballpark estimate: how many
Yeah.
implants have you placed?
Placed. Oh my lord. Huh. And it's been. Oh, I'm not including residency, right? Just right after I started working.
You can include residency.
Oh Jesus. I'm probably. Oh man, 5 to 10,000.
Okay.
I'm gonna look at that ballpark. Yeah, so I'm very consistent. I'm doing a lot more now. Like last
Okay.
week, I might have done close to uh probably about 75.
Okay.
Oh,
You
Jesus.
know what I
Okay.
mean? Yeah, because and that's another discussion I want to have. How many
Hmm.
general dentists now just seem to want to give up on a tooth,
Right.
and patients are now kind of falling onto that too. They're wanting to
Well,
give up on a tooth way faster than.
we'll get back to that, Walter. Go
Yeah.
ahead, Leroy.
Okay. All right. All right. Go ahead. Go ahead.
Back to the bus. Let's get back to
Go
the
ahead.
bus.
Go ahead.
How
Go
many implants have you placed, Leroy?
Last I counted, and I'm kind of a weird like that.
I need
I
to
was
start
at
counting.
I was at just under 1,600.
Okay. Walter, how many implants have you restored?
After residency, 0.
Yeah. Okay. Leroy.
After residency,
Same question, Leroy.
that's an easy count.
Yeah.
That's a completely easy count.
All
0.
right.
I'm gonna tell you that right now.
Same question, Leroy.
I restore all my own work.
Oh
Okay.
man.
So about
So
12.
as a patient, if I'm going to go to a provider,
Right.
do I want to go to a specialist that will
Oh
place the
Lord.
implant and
No,
send
I
me
see
to
where this is
somebody
going.
else, or
that's great. Yeah.
do I want to go
Yeah.
to somebody? Because as a general dentist, that's part of the reason a lot of us get into it is if we have a surgeon in our area that isn't as proficient, where they're just looking at that space. I can get an implant in there, but they're not looking at the function of that implant afterward. Is there a benefit to the patient going to somebody that has to deal not only with the surgical aspect, but also the restorative aspect?
Right. And that's actually a legitimate question. That's a great question. And I'm not taking it personal at all, because it's actually very true, man.
And it depends on what perspective you look at it. If it's something that is requires kind of a multifaceted a surgical approach, you might want to put the surgical part in the hands of the surgery specialist, right? For your run-of-the-mill number 19, where the occlusion is great, restorative space is great, no parafunctional habits, general health is great, I don't think there's any reason why that would absolutely need to be referred out, given that the general dentist is adequately trained, right? But I think we all need to look at it more of as a team approach, as opposed to a GPs versus specialists. They're hoarding the cases that I want to do. There's cases that are outside of my wheelhouse that I've referred. There's patients that are kind of more complex. And I don't want to do them the disservice of trying to bite off more than I can chew. And I think in general, we need to see, and dentistry, as you guys know, it's a dog eat dog industry, right? We need to be a lot more collaborative, because at the end of the day, what we're looking for is the patient outcome, right?
Right.
There's enough money for all of us to eat. There's enough patients for all of us to kind of get our work in. But to answer that question, for your run-of-the-mill general cases, I don't think there's a benefit or a disadvantage to either way, right? As long as it's properly trained. But I have seen some cases, not to get on the specialists, where the implant was just placed where there was a bone, and that's about all the credit you can give to the case.
And let me speak on that. No, let me speak on that. There's two things I'm going to actually say. First off, I actually love working with somebody who does implants, just like I like working with somebody who does, aesthetic cases, because they can see more of a need for, hey, let's do aesthetic crown lengthening, or they can say, hey, this needs to be an implant here. So they're actually one of my best referrals. And they're probably one of my easiest referrals, because they send me everything, surgical guide and CBCTs and so forth. So it makes my life really easy. Like, I mean, it's almost like if I don't like slam dunk this, like I'm the asshole.
But even if you do slam dunk it, if you have a general dentist that sends you a case and says, put an implant in here, and you do the absolute, work of art putting that implant in there, and the general dentist, does a cement retained crown, squeezes a bunch of cement down around the implant, then you look like you're the idiot because your implant failed.
But see, that's another discussion. If he's doing the implants himself, he knows better.
Right.
Because the second you do that one time, then the onus is on you for everything.
Right.
And again, that's what I'm saying. Like, having somebody who places implants, they're the best referrals, because they already know, I don't want to deal with this. I need this to go perfectly well, because implants, one thing people don't understand, and that's why I hate when people get so excited about implants and think everything needs to be implant replaced, right? Because implants, when it fails, it's a destructive failure. Yeah. It's not just like, this area hurts. The bone is gone. The soft tissue is gone. Like, it's catastrophic, Right. And so that dynamic of who's placing the implant, I don't care. Just know what you're doing. But we're gonna get on that, because I mean, you guys are about to have me go on a tangent. I say this a lot. Just know what you're doing, and I'm fine with it. You know what I mean? And know the knowledge, like have the knowledge to be able to just say this didn't go well, or take onus on situations, right? If the crown was the reason, because traumatic occlusion does exist, if that's the case, then let's talk about that. Don't always just point to the surgeon and say, oh, it was the surgeon's fault.
Right.
You know what I mean? And that's another, anyway, I don't want to get on that, but I you're right. We're very selfish. The dental community is very selfish when it comes to, let me keep everything, let me hoard everything. And it's getting worse. It's getting worse, because now we're starting to look at models like the corporate model and going, well, if they can have everything in house, why can't I just keep everything? Because I'm afraid to send it out because it may not come back to me.
Right.
And I really believe that selfishness is something that's just kind of, if it's growing. And again, correct me if I'm wrong, guys, but I feel like it's growing.
I think it depends on the area. If it's an area that's has a lot of competition, in areas where there isn't a lot of competition, there's more or less of that. But yeah, it's definitely growing in some areas.
Yeah, I see that where I'm at. So I have I work out of probably 4 offices, but 2 of them I'm partnered in. One of them I bought in when the area was still a very kind of young, growing area, and I was probably one of maybe 4 offices in the entire town. Now there's probably like 40 or 50.
Oh wow!
And then the other office is in a more metropolitan area called Bellevue, Washington, and it's literally the battle row of dentistry, right? So
I
in
love
my
Bellevue,
building,
by the way. Love Bellevue. I went there for a wedding. Great place. That bridge, that toll on that bridge is crazy though. Like,
it is.
In the morning it's like $2. At nighttime it's like $50. That part killed me. I'm walking my ass across the bridge, and we'll talk about this later. Yeah.
The best thing to do is don't even think about it and just surprise yourself when you get that bill in the mail.
But go ahead. I'm sorry. Go ahead.
But it's the battle row of dentistry. I mean, there's 2 offices in my building. There's 3 offices in the building next, and it just keeps going on like that. And there's so much pressure financially, especially since if you're a PPO network dentist, your fees are getting cut. And so I think we're very collaborative, like Kyle said, when there's not a lot of us and we're all eating, right? When all of a sudden there's too many puppies in the kennel, and the insurance companies are squeezing us by decreasing our reimbursements, we're all turning on each other.
Yeah, people start filling up bags with gasoline in plastic bags. It's when things get scarce, people do crazy things.
Listen. I know you're referring to the Bellevue dentist that did that, right?
What?
Oh, there it is. Go ahead.
Wait, are you? Was that just like a off the cuff analogy?
I was talking about the gas shortage down in the southeast.
Listen.
Okay, so, I unlocked something here.
This guy out in Bellevue, I'm not going to name names, but he was actually a year ahead of me in dental school. And he did the GPR, and I was a 4th year, so I had to do some of my ER rotations under his supervision. But he was a prick from day one, right? But he last year filled up a bunch of bags with PPE, poured gasoline, and was trying to burn his office down to collect the insurance money. So that's when you started talking about filling up bags with gasoline. Okay. I thought you were specifically referring to, because he literally was trying to burn his office down to collect on the insurance money because times were tough.
Yeah.
But yeah, filling up gasoline.
that pisses me off, because at that time PPE was very harsh and hard to find. Now you're pissing me off. You know what? I don't care if you burn like your couch. I don't care. PPE was gold at that time. Yeah. Now you're just an asshole. Now you're just an asshole. Wow. Okay.
Walter, let me ask you this real quick.
Yeah, please.
Because a good friend of mine is a periodontist.
Okay.
His name is Kevin Suzuki, an amazing clinician.
I know Suzuki. He went.
Oh, you do?
We went to Pitt, right? Yeah, great guy. He was about 4 or 5 years ahead of me. I know Kevin.
No. You must be thinking about his dad.
Oh, okay.
I'm talking about young Suzuki.
Okay, never mind. Yeah, because he was the dean of the dean of the perio. Suzuki was the dean of the perio department at Pitt.
Okay.
The dad.
Yeah,
the dad
so this is his son.
Okay, I'm sorry. Okay.
Younger demographic here.
Got you. That's all good.
But he was telling me how in his office, if they do the bone graft, they have an agreement with all their GPs that they have to do the implant. So they were running into issues where they would do the bone graft, the GP would then go in and do the implant, and if you have failures, who do you blame, right? And what do you guarantee, and so forth. And I'm wondering if you've run into having doctors refer patients to you just for the bone graft, and are you okay letting then someone else do the implant?
I'll be honest with you. I've never had anybody refer to me just for the bone graft. Well, no, I shouldn't say that. No, they didn't mention that directly, right? So I will do the
Mhm.
extraction bone graft membrane, and then the patient leaves, and then I
Ah,
just like, well, hey, we're gonna get you back on a schedule, and then I'll hear that the implant was placed by the general dentist. So in that sense,
gotcha.
I guess that's what they're doing, right?
Right.
Um, if it fails, you're the one that placed the implant. That has nothing to do with me.
Yeah.
You know what
Okay.
I mean? Like to me, it's if you would just let me start from beginning to end, then you know what I mean? Because there have been some times where I've had oral surgeons do the extraction and the patient comes to me and I'm like, hey, you might want to go back to the oral surgeon to finish
Right.
everything. And I've said
Right.
that. Like I've turned people away, like, go back because I don't know how the whole I don't know what he saw or she saw when they did the extraction, the socket. Did you get rid of all the granulation tissue? Did you know what I mean? There's so many factors that I was not in control of.
Right.
Mhm.
You see, is it something that's on a regular basis? No, but if I know the oral surgeon, I usually just tell them to go back to the oral surgeon. They're capable enough to do it. So I personally
Gotcha.
don't, you know what I mean? I personally don't tell somebody, go do the extraction with this person, come back to me for the implant. I don't do that. But I
I
know
see.
a lot of GPs who do that. Like they're
Right.
like, oh, the tooth was root canal treated. That's the biggest one. Oh, it's root canal
Right.
treated or it's fractured. So I can't
Yeah.
do the actual extraction, but I'm capable of doing the implant, which is to me the harder part.
Right.
Right. Right.
The more intense part. You know what I
Right.
mean? Like to me, I
Right.
thought that was the hardest part. But okay, go ahead and do what you. So these are the discussions that I have a lot where I'm just like,
Right.
so you want to do the more complicated part, but the part that would take me like 5 minutes is the part that you're referring to me. Okay,
Right.
it is what it is. You know what I mean? So,
Yeah.
but yeah, I tell people, look, if I'm not placing the implant, that has nothing to do with me. And I think
Gotcha.
Suzuki should think the same way. He's not in control of the implant part, and that's the part that has the highest failure rate. It's not the bone grafting. You
Right.
know what I mean? So
Right. I see. But I agree with you. I've had a lot of associates that want to learn, and me and my business partner actually started a series of curriculums to teach GPs, and
okay,
we're AGD instructors now for the last couple of years. Um, but my big thing is you shouldn't be doing implants unless you're extremely comfortable with surgical extractions,
yep,
right?
Mhm.
Now, you don't have to be doing full bony thirds. I get that. But if you cannot lay a flap, if you
mm-hmm.
cannot have the creativity to see where can I remove bone, how can I section this tooth,
Mm-hmm.
how can I, like reverse Tetris this tooth out of here,
Yes,
you
yes,
probably shouldn't be doing implants. But a lot of doctors, you'd be surprised, like you said, they don't want to take out this root canal molar, but they want to jump on that implant, right?
Yeah.
And what that tells me is that if you run into any complications in placing this implant, you're lost.
that's right.
And why I'm a big proponent in that, if I'm doing 1 through 3, I'm at least prepared for what happens or what could happen at 4 and 5.
Right,
Mhm.
You
right,
know what I mean?
right.
And that's a big pet peeve of mine is doctors that just want to jump into the glory of doing implants, but
Right.
yet you, and the reason we started teaching courses is because we would have associates that wanted to learn, and you just assume they know what you think they know, and then partway through the surgery you're sitting over their shoulder and you're like, holy shit, they don't know nothing, right? You're telling them to lay a flap, you come back in 2 minutes and there's like just a tiny, like they pushed the sulcus over just a little bit, and you're like, I said lay a flap, oh, it's right here, no, a bigger one, bigger
Right,
than this, like,
right,
okay, quit, stop.
right, right.
you know?
The funniest thing I ever saw was I went to a conference. I think it was the American Academy of Periodontology's yearly conference we went to, and it was in Orlando.
Mhm,
And we just happened to hear that Carl Misch was teaching a class.
mhm,
So two of my buddies and I, we decided to just go over and just listen to it, right? And so we went there, we introduced ourselves to him, and he said, "Yeah, just hang out in the back. Who cares, right?" So we're listening, and literally all he was doing was reading his book. Because if you read the book, you understand, right? And
right,
I'm watching this, and he's just basically going over the book, chapter one,
right,
summarized, right? And I was like, people are paying to listen to him read a book. Why don't you just read the book and go to the you know what I mean? Like it was the craziest thing to me. Like people instead of reading a book would rather pay somebody to read to them.
right,
But this is the mentality that people have, right? Instead of just learning the basics, so you have the foundation, then you can actually ask intelligent questions, and you can actually challenge yourself a little more. You say, okay, I'm gonna just pay for everything, but I won't pay enough to learn and be proficient. I'm gonna pay enough to just be mediocre, so I can just at least start.
Exactly.
So Walter's recommending for people that don't place implants that want to get into it to start by doing some research, reading textbooks. Carl Mush's book is a really good one. What would you recommend for people that are trying to get into implants? What is kind of the minimum stuff you need at the practice?
What's your practice? And I'm sorry, and what's also your program too? Can you talk about that as well with all that?
Oh, yeah. So I'm a big proponent of immersing yourself, right? So first of all, what you guys said about reading the book, to me, and this is something I taught my kids early on, like read the chapter before the class where the teacher is lecturing on that chapter. Okay, so you're not trying to hear, learn, process, and integrate all at the same time. You've read the information, you've absorbed it, and now you're getting the context. Now you're getting the nuance. Now you can understand and ask questions that are at greater depth because you're prepared before you go into this lecture, right? The other part of it, you have to be able to know that you're going to be devoting time and money. Some of the classes, yes, they're weekend courses. That doesn't make you proficient. It's a weekend course, right? Some of the curriculums are several weekends over a large span of time. That's good because you're getting a continuum of education with like a consistent philosophy. And there's different philosophies, but it's good to not have all the time a hodgepodge of different ideas and viewpoints. It's good to have some continuum, right? And then my biggest thing is find a mentor. I was lucky in that I had my business partner. But I don't think dentists really, or GPs really realize that a lot of the specialists out there love to teach, love to have you around, love to share knowledge with you. One of the first things I did when I graduated is I went to there's an amazing oral surgeon out here, Carl Johnson. First thing I did is I hit him up. I said, hey, can I come shadow you? I just want to see how you approach things, how you set up your day, how you start a surgery. Because my niche was, in the beginning, wisdom teeth, because I had done a third molar impaction semester at the University of Washington. And so I felt super comfortable doing all sorts of thirds. But I wanted to see how the masters at that did it. And so I just, find a mentor that's a specialist that does what you want to do, that is what you want to be, and spend time. It might cost you some lunches or dinners here and there, or some drinks and appetizers, but specialists in my experience have been very forthcoming when you come to them with just a genuine thirst for knowledge and a genuine curiosity just to see what makes them so special, right? And so finding mentors, I think, is huge because there's only so much you can learn from a textbook, only so much you can learn by putting implants on a plastic jaw or a pig jaw in a class, right?
Really? Okay.
And you want to see it done before you attempt to do it live. And if you foster a good relationship, they'll be there for your first couple cases.
On the other hand, I had an experience in an area that I lived. There was one oral surgeon on the island, and I had sent him lots of cases. So I've extractions, implants. Finally, I said, hey, do you mind if this is my patient that I'm sending to you for an implant. Do you mind if I come watch? I don't let people watch my surgeries. Okay. Hey.
Oh, wow.
Wow. Okay, buddy. I guess I'm going to be starting to place implants here pretty soon.
There it is.
Oh, Lord.
The jaded lover.
There are people out there. So anybody that, just find another person to refer to if you run into somebody like that.
Right.
Yes, if one door gets slammed in your face, knock on a different one.
Well, you brought up what's it called? Howard did to you by talking about drawing blood for healing process. Can you just kind of break that down? Because I know what you're talking about, but can you break that down? Okay, it's my daughter. Sorry,
it's making a cameo.
You're right. Yeah, she doesn't care that I told her that I'm going to be busy. No one ever listens to me in this household. But break it down for us, like what the whole drawing blood and spinning it down and trying to get your body to kind of help you heal process looks like for you, and why you started doing that.
Well, so the process itself is it's nothing necessarily that was necessarily championed by dentistry. A lot of stuff that we do in dentistry, especially when it comes to bone, we've taken from orthopedics, right?
Yes.
But the process is pretty simple. You take someone's blood, you spin it at a certain protocol, and you separate out the red blood cells from the fibrin, the platelets, some white blood cells. Okay. And the reason you're doing that is you're trying to concentrate the fibrin and the platelets because the platelets is what's really kickstarting the healing process in any blood clot. Okay, they're releasing all your needed cytokines and growth factors. They're really fostering the the coagulation that happens to keep all that stuff in place as long as possible. But your natural clot is only about 4 to 5% platelets, and the rest is red blood cells. Okay, well, you can concentrate it, and now you're at 94, 95% platelets. So technically, you're increasing the amount of potential growth factor and cytokines in any particular surgical site by almost 20-fold. Okay, the fibrin network is great because all the studies, and Dr. Marone's textbook is a great textbook to read. It's called Understanding PRF, is the latest one. The fibrin helps keep those cytokines and growth factors in that space to have their desired effect longer than a natural clot would have. So all you're doing is it's not a silver bullet. It's not a magical pill that all of a sudden you're going to get, D2 bone everywhere, in tremendous amounts. But it's a great way to facilitate and aid good surgical protocol and healing. So that's what we're doing,
Okay.
right? Where I got into it, I think it was as simple as I was at an AAID convention. I saw Joseph Chacron lecture. I have qualms now that I'm a bit more educated as to some of the claims that group is making, right?
So
But
it's not the fountain
anyone
of youth.
that's
It's not the fountain of youth.
it's not the fountain of youth.
Okay. I just want to say that, without getting in trouble. I just
Yeah,
want to say it's not a fountain of youth. Okay, got it.
it's
Okay.
definitely
Let me
not
move.
the fountain
Let
of
me
youth.
move on. Let me move on.
But it has its utility, right?
Yeah.
Both biologically and also just physically. You're able to make these the bone graft that you're using that we used to just hydrate with saline. It makes it more sticky, easier to handle. You don't place it on the, if you're doing an onlay graft and it starts kind of running all over the place. So there's great actual practical utility to it as well, and it's all natural. It's not exogenous. It's not something synthetic. All you're doing is taking the blood, spinning it, taking a portion of it, and put it back in the surgical site. So for me, it makes total sense. It's not a replacement, though, for good, sound decision making in your surgical protocols. Like that if that's not there, PRF ain't helping you, right? And so to reference what the conversation we were having before we started recording, yes, Howie did try to set me up by pitting me against the great Carl Misch and some of the stuff that he has said about PRF. But luckily, I've done this enough times where I was able to reframe it and basically say that there is a philosophical argument between things that the camp that I represent, which is, yeah, it's definitely a good adjunct. And there's camps that say, hey, you use only PRF and you can get 5 millimeters of vertical and horizontal simultaneous augmentation with no tenting screws, just special sutures. You know what I mean? Like yes, when it comes to that kind of stuff, it's voodoo. And mind you, when in all my courses, I always take updated photos because I have a pet peeve about stale photos and presentations, right? The people that present this stuff have been using the one case in like the last 7 years that I've been seeing these lectures, and I don't know, both of you may have seen this. Every time they talk about both vertical and horizontal with no tenting screws, in 3 months you can place an implant. It's the same exact case, that one case.
Yes. And it's not just that. It's everybody does this. And
Yeah.
You're right. Like if you don't continue to, you'll see. You're like, wait a minute. I remember you talking about this, and then again, you'll look at it again, be like, okay, wait a minute. That's the same tooth that he mentioned.
Yeah.
But can you explain to us, like, why would you do this? PRF, right? versus just doing what we've been doing for, before we started doing PRF? Like, what is the benefit? Is it we're trying to just make that area heal a little faster? Is it's less swelling? Like, what is the
Right.
reason for a lot of this stuff? And I know the answer, but I want you
Right.
to.
Well, my personal reason is
Yeah.
both. I think there is enough evidentiary history to show that there is, decreased reported morbidity, slightly decrease in incidence of infection. If depending on how you look at the data on the rate of bone turnover, right? So, they take plugs and do they look at it under a microscope and see that at 4 months with PRF, it's what it looks like at 8 months without PRF. I mean, you have to have kind of a skeptical eye when you look at that. I'm not changing my timelines that much because of PRF, but anecdotally, that's the biggest kicker for me is because I have half a career before I introduced PRF to my protocols, and the second half of my career where I did. I can tell you an absolute difference in soft tissue healing,
Yes,
in reduced swelling.
that's right. Yeah.
The bone is the bone. I can't do the histology on you to tell you whether the bone is any better than it pretty much feels the same as it did before, right? But the soft tissue improvements that I get, especially in that first 3 to 4 weeks of healing, and also just the practical utility of it, to me, that in and of itself is worth its weight in gold.
And I think that's the discussion that a lot of people need to have, like a realistic discussion to say, and I completely agree with you, by the way, the soft tissue healing is incredible. Even after a week, it
Right.
looks like it's been healing 2 to 3 weeks.
Yeah.
You see, and then we all say that the critical time of healing is usually the first week or two. That's the most critical. And that's the part that I scare my patients and say, this is it right here. If we can do well here, we seem to do pretty well going forward, right? But the first
Exactly.
2 weeks is usually the critical time. And so if you
Right.
can kind of speed up that soft tissue, so we can get that closure, we can get that, internal healing. That's key. We can get all
Right.
that growth factor in there. That's key. So that I completely agree with. And other
Right.
stuff like, you can all of a sudden you lose 30 pounds and all this extra stuff that PRF has been magically known to do. That, I mean, that part I'm just like, all
Right.
right. But you're absolutely correct. I 100% agree with you with the soft tissue situation.
Yeah.
When it comes to PRF, like, how much would that be for somebody who wants to get involved in this? Classes, and then the system, the centrifuge, and all that stuff. How much would that be? Rough
Your
estimate.
initial investment,
Yeah.
Honestly, if you're pretty experienced, learning the phlebotomy and learning the actual protocols is pretty easy,
And
right?
who
I mean, you
draws the
could
blood,
do
by the
that.
way?
Well, it depends. In the state of Washington, as long as you're a licensed provider, you can do it, right? In other states, you have to have a separate phlebotomy license to be able to draw the blood. So it's kind of state by state. Here, I do it. I've had assistants that have had phlebotomy training, and although I love them dearly, there was a lot of misses, right? So it's just way easy because it doesn't take long. I just, and plus, and a fair amount of those cases, I'm doing IV sedation anyway, so I'm already getting access, and so I'll do the blood draw, I throw it in the centrifuge, I'll do my surgery. By the time I'm done, taking the tooth out, the vials have spun, and once they've spun, you can just let them sit there for hours if need be in the tubes before you actually prepare them and flatten them and so forth. So there's no rush once you've done that. The only rush is from drawing the blood to get in the centrifuge, because the blood's going to start coagulating if you wait too long, and the separation isn't going to be as complete, right? But I mean, you could take a course, and courses range anywhere from usually, a little under $1,000 to a couple $1,000, depending on the length and obviously the name of who's giving them. But it's not terribly complicated compared to some of the other procedures that we do. A good centrifuge will probably run you about $1,000. And mind you, a centrifuge is a centrifuge. And when I first started doing it, I bought a $70 centrifuge off of Amazon.
Yes,
Okay.
Amazon.
Okay. And
I've been known to dabble in Amazon.
Yes, and it works just fine. Now, mind you, I'm not going to buy biologics off of Amazon. Okay, so let me put that out there in case anyone's listening, getting the wrong idea.
Right.
But a piece of hardware that's just meant to spin The only thing the dental, the ones that are, I guess, FDA approved for dental use, they have the label dental on it, right?
Right.
And now they've been kind enough to kind of put in some presets for you. So, like the Chacroon centrifuge is great because it's got the presets for APRF, injectable PRF, APRF plus, PRF for women, PRF for men. So you don't have to do an equation to see what speed with this centrifuge, with this rotor, is this going to give me 200 Gs or 400 Gs or whatever you're looking for, right? So, but Salvin has a good one. Chacron has a good one. Marone's new. Marone actually has a great one on that. The tubes are suspended instead of fixed. So when the centrifuge starts turning, the centripetal force actually makes them horizontal. And so instead of being at a pitched angle, now when it starts spinning, it's horizontal, and the separation seems to be a bit more complete. But yeah, so there's a ton of them on the market. So you all in, you're probably looking at about $5,000 to really get started doing it, between classes and supplies and all that. But so it's not terrible. I mean, there's definitely much more expensive things to invest in dentistry.
Okay.
For people looking to get into implants, this seems to be a debate whether do you need a cone beam? Are you good with just a pan? Are you good with periapical? What's your opinion?
Oh no! Listen, let me give you, and both of you are probably old enough. Kyle, how old are you?
I'm 35.
He's young.
Okay,
he's
so
young. He's young.
You're a little
I'm
younger
39.
than me. So
he's young. We ignore him. Let's ignore him.
So that 5-year difference might mean you haven't done a poor man's cone beam, right? But one of the first implants I did was you take an alginate impression and you pour it up in stone. Okay,
Yeah.
You numb the patient's gum, and you sound the bone, and you read off numbers to your assistant. 3 millimeters, 2 millimeters, 3 millimeters. You saw the cast, so you can open it up and have your section, and then you outline, given that sounding, where the bone is. Okay, and that was one of my very first cone beams I ever took in dentistry, right? Now, obviously, I mean, you could make the technical argument if you're super duper experienced and you got a molar and the ridge is yay big, and you can see on the PA the IA is way down here. You technically don't need a CBCT, but my standard policy and recommendation for everyone is CBCT is standard of care, period. And I have CBCTs on all my extractions and bone grafts. Because I feel like you need to have a 3-dimensional strategy when you approach the foundation you're trying to create for that future implant.
Okay.
Right. And the cost of the CBCT has gone down so much. I mean, my first CBCT was like $150,000. It was an instrumentarium. It's nice because it takes full views here. So if you do any airway stuff, it's great. But now you can get it. My buddy that opened a practice in Texas got a used, did he get a used Gendex? Takes great CTs. He got it for $28,000.
Oh, wow.
That used to be what a good panel machine would cost.
Right.
Yeah. No, Walter mentioned we both did the VA GPR at the VA hospital in Pittsburgh. We had a cone beam CT when I was there. I don't know if, since Walter's so much older than me, I don't know if they had it there when he was.
He didn't have to say that.
But all the
we used to throw rocks at each other.
But all the implants that I placed there, I had never took a cone beam on them. It was based straight off a pan. I don't know Walter's experience, but as somebody that's looking to get into implants, do you really need to drop that kind of money on equipment if you take the education and you find out this just isn't for me? Now I'm $100,000 into this, much like when you go to dental school. Second year you figure out I don't like working on teeth. Well, you're invested now, you have to do it.
Right Well, there's 2 ways to look at it, right? So CBCT has more utility than just implants, right? So let's say you do root canals. It's
Right.
great to see if there's an MB2, right? It's
Right.
great to see if the canals are 2 and then turn into 1 and so forth. So there's
Right.
more utility than that.
Mm-hmm.
And then at the cost that you can get them these days, it's not as cost prohibitive as it used to be. But then also, even if you don't want to invest in your own CBCT, I mean, I get a lot of doctors that refer to me just for the cone beam,
Right.
and I burn on a CD, and they do the implants. So, and then there's a lot of imaging centers where,
Yep.
the patient pays, $300 or $400, and they get a cone beam, and they give you the raw dicoms on a CD, and you can, whether you're using Anatomage or Blue Sky Bio, you can treat and plan it that way. So there's always options beyond that. Now, if you don't have the option of a local imaging center or doctor that does have a CBCT, and then to backtrack just a moment, I've known a lot of doctors that work in a building with other dental professionals that have CBCT. So you might be in a general dentist in a building that has an endodontist or that has an oral surgeon, and they don't mind taking the CBCT for you.
Mm-hmm.
But it's hard for me to say, although if you have the skill, if you have the guidance, it's not absolutely needed. But I don't trust people to be able to be good to assess their own limitations well, if that makes sense. And so I would rather just make a blanket statement in 2021 that say, hey, everybody just needs a CBCT, than trying to, create these gray zones when it comes to diagnostic imaging. And that's just a personal stance, and it's not even a soapbox I really stand on. I just cringe because I have seen some cases out there where even with the CBCT, some really poor decisions were made. So I would hate to increase the incidence of of decisions being made with even less diagnostic tools at hand, if that makes sense.
And I honestly think, and to kind of jump on that, I honestly think a CBCT allows you to push the limit just a little bit more, right? No
Right.
CBCT, and you have let's just say you bone sounded, and you have a ridge that's 7 millimeters. I would think, okay, well, 1.5, 1.5. Okay, maybe I just should only put a 4.3, or no more than a 5.0. Yeah, probably like a 4.3, 4.5 in that space, right? But if you get a
Right.
CBCT, you know exactly the width. Then you can treatment plan on that software to get you the exact implant that you're going to feel comfortable with, and that software actually gives you that plus or minus that 1.5, 1.5. So the safety zone is also there as well.
So
Right.
are you doing guided surgeries for every implant also then? Because you can
Okay. Yeah,
have the
that's it.
information on the cone beam,
Right.
and you can just have a bad day and line it up wrong, and
Right.
if it's not guided, that cone beam is worthless to you.
And can I add on to
Mhm.
that? You mentioned how a lot of doctors don't have the surgical skills.
Correct.
And I feel like a CBCT also kind of lowers your safety margin. So basically, it allows you to think you're invincible, right?
Right.
And then whenever you have an issue, they don't know how to get themselves out of that issue,
Right.
right? Because they think a CBCT should be perfect.
Right. Right. Well, there's that great question, Kyle, because I think you brought up a good point as you were talking that made me think back to the pano thing, right? How many times have we seen a two-dimensional X-ray where it looks like there's like 15, 16 millimeters to the IA in a molar space, but then what you don't see with the CBCT, there's this lingual shelf,
Mm-hmm.
Yeah.
and so you only got about 8, 9 millimeters before you busting out the floor of
Right.
that shelf,
Mm-hmm.
right?
Right.
So I think even in areas that might look straightforward, CBCT can give you great added information. Walter,
Well,
you're right in that it can give you a false sense of security. Case in point, a section is not a section, right? A section is only a true perpendicular section if you've lined up the image perpendicular to that section, right? How many times have you looked at something and oh, I got 13 millimeters, and then you realize, oh, it's kind of angled like this. So you're taking a diagonal slice, and then you
Right.
correct it, and you're like, oh crap, I only got 8 or 9,
let's see.
right?
That's a
So
knowledge that the people don't have.
they don't, and
They
I
believe in
think
the machine.
yes, and but now with that, if you're going to get a CBCT, I think it's prudent that you get trained on
Yes.
how to properly diagnose.
Yes.
Because I get a lot of, or some of the doctors that they refer patients to me. We give them the raw DICOMs. They might shoot me an email, say, "Hey doc, what do you think about this?" And it'll clearly not be a doable case.
Mm-hmm.
And so the question tells me more, like it makes me, the fact that you even had to ask worries me more. And so usually with those doctors, I'll say, "Hey, why don't you stop by my office? Let's go over some pointers of what to look at, how to really interpret this, how to manipulate the software." Because, I may be thinking, oh, it's as easy as an Automagic software, but you might be looking at a very like basic, whether it's an iTero or a basic, Blue Sky Bio, where you may not all have all the bells and whistles I have at my disposal. And I may assume you have the ability to interpret that the same way that I do, but you don't, right? So I like to bring them in the office and just really have a one-on-one, for 20, 30 minutes and give them some pointers. And in our course, our Implants 101 course, we spend a good hour just on CBCT interpretation, how to manipulate the software, what to look for, what are some of the things you're probably going to look at and not know what you're looking at, and when to seek guidance and so forth, right? But yeah, that's paramount. But what I'm seeing more so, where I'm seeing danger, is these labs that are pushing guided surgery on everybody. And I only do guided surgery maybe about 20% of my cases, and it's almost always anterior cases where precision is, there's no room for error, right? Aesthetically, functionally, biologically, like you have to be on point. But you have to have the background to know when that guide is off. You have to have the eyes to look at that screw hole in your guide and be like, huh, that's not how I envisioned it. That's coming a little bit more buckle. So it's not an end all be all, but it can give you a lot of false confidence. And you always have to remember, it's a certified lab tech that's designing your guide.
Thank you.
So when you send it off to XYZ lab and they send you these images for you to approve, a lot of doctors are like, yeah, that looks good. Yeah, go ahead and make it. Okay.
Yep.
That's what they do for
Yep.
Invisalign too, by the way.
Yeah.
That's another story. That's another story. That's what they do for Invisalign.
Right. And it wasn't until my business partner bought a 3D printer and started playing with Blue Sky Bio, designing his own guides. And we really realized, like, holy crap, if you don't marry the STL to the DICOM file perfectly, you're completely off. I don't care if it's a guide, you're guiding yourself right into the next route, or you're guiding yourself right outside the bone. And I don't know how much trust I put on someone that's a technician that's just now starting to do guided surgery, and doesn't have that keen eye for, the expected restorative outcome, the restorative space, and the soft tissue considerations. So it's a very complicated game, and I feel like a lot of industries, whether it's the labs, whether it's the 3D companies, are trying to oversimplify it for doctors. And I think that's doing us kind of a disservice.
Okay.
Do you guys agree?
Yeah. Oh, I completely agree with you.
Yeah, absolutely.
I completely agree. I think that people are doing too much when it comes to depending so much on the machine instead of their own eye, right? Like you have to sit there and say, this does not look right, or this is just not right. It's kind of like putting your car in autopilot and be like, all right, cool, I'm good. You know what I mean? Like, no, you still have to be there just in case. You know what I mean? Like, that's another. But okay, let me ask you this, and we'll kind of wrap it up here. But I get this question a lot, and I bet you get the same thing. So, what's your favorite implant system, or what implants do you like the most? Right? I get that a lot. And for me, I'm like, okay, like I can't pick between my daughters. Like you're asking me, you know what I mean? Like I like them both equally. I have no choice but to say that. And I always say, like,
that's because we're recording right now. You got to favor.
Right, The second we end this, I'm gonna be like, look, the little one is my favorite. Let's be real. But the reason why, we joke about this, but the reason why I'm saying this is because, to me, if you look at the research, implants, almost every time you look at a research for implants, it's like has a 95 to 100% success rate.
Right.
I think it's what you feel comfortable with. I think it's what you like, right? So don't let these tech or these reps come in there and think that their implant is so special and all this. I have yet to see maybe one or two implants that actually changed the game when it became more aggressive threads. But besides that, it's always been kind of the same. Implant is an implant is an implant, just a different name. But I want to kind of get your opinion on this.
I agree with you. And listen, I grew up on Zimmer. So in
Mm-hmm.
school we had our implantology course, and it was run by Zimmer.
Mm-hmm.
One of my favorite reps ever. Her name is Myra Haynes. She works for Affordable Dentures now, as a regional implant specialist. But she is one of the most knowledgeable. Just she really kickstarted my implant life. So I always have to give credit to Myra. I love her to
Awesome.
death.
Awesome.
But I grew up on Zimmer. When I started practicing with my partner at the time, he was placing ankylose. And then we kind of dabbled into kind of copies of Nobel, copies of Astra. And at the end of the day, there's only a couple things that I would say I would adhere to strongly.
Okay.
I definitely believe in conical connection versus non-conical. And the more conical you can get, like with an ankylose or a bicon, I think there's added value. Now, is it game changing per se? No, but if I had my choice in myself, I would say the larger the platform switch, the better, right? If I was
Okay. Yeah.
choosing an implant to be put into me.
For what reason? Can you go
But
in depth with that real quick? For what reason? Why would you want?
well, mechanically, I think what you see is that it offsets the distribution of stress from the connection point. When you have a flush like hex connection, and you start seeing, you're always going to have, because anything that's manufactured is manufactured with a certain amount of tolerance, right? So there's always, even if when you screw it down, there's going to be a little bit of wiggle room, and it puts the stress at the abutment to implant net connection point. When you add a conical feature and you offset it, it actually distributes that stress along the top portion of that implant to a greater extent. And I think I think it's evident that the bone favors that different type of distribution of stress a little better. Now, does that mean that's going to change your success rate much? Probably not. Okay. Straight implants versus tapered implants, hex connection versus conical connection. I think in higher aesthetic areas where I may have multiple implants, I may want that cushion of reducing that zone of irritation and potential bone loss by using a conical connection, which has definitely been observed. But my biggest thing in choosing an implant system is the prosthetic components.
Okay.
How common sense are they? For instance, for the longest time, I was using a brand, and because I'm not going to disparage it, but because I'm going to say some less favorable stuff about it, I'm not going to name the name, but it's a
Yeah,
copy
don't do
of,
that. They didn't
yeah,
pay us for anything.
no. But it's a copy of Nobel, right? And it's compatible with Nobel. But when you look at the impression copings and the abutments, they're very short and stocky from the hex part through the conical part and the base, right? So if you're the type of person that likes to maybe bury your implants 0.5 millimeter to 1 millimeter, or if let's say you have a canine tooth and there's a little slope of bone, and you really need to be able to get that impression coping in, but you're blocked out by hard and soft tissue. It's nice to have a prosthetic component that's a little bit longer and more conical that fits into tighter spaces without putting pressure on the soft tissue in the bone, both at the impression phase and when you're delivering the prosthesis. So right now I use, it's a Korean company called Dentistry.
Okay.
And that's the premier thing that I like about it, is the fact that the impression copings and the abutments have a long conical above the implant design.
Okay.
So that way it's able to navigate that, even tight soft tissue or slightly buried implant a lot better. So I choose based on that, and obviously the availability of the rep, right? If you need a piece, you want to be able to get it the next day, or if you got a local guy the same day versus having to wait 2 or 3 weeks between, ordering. But at the end of the day, I'm pretty agnostic. I feel like any implant system, if you place it right in the right conditions with the right restoration, you're going to be successful.
Yeah. And it's actually funny that you bring up broken implants, and we'll end it here. I actually just went through my history of pictures, and this actually came, I want to say, like 2 or 3 weeks ago. And I'm not sure if can you guys actually see this?
You got to turn your
yeah,
background off.
Let me turn my background off so that no, because I gotta show you this. This is just amazing to me. and I don't think a lot of people understand how what's it called, important occlusal force is. You know,
Mhm.
It's something that I feel like we need to have more discussion with, more understanding of, that we don't,
Right.
right? So let me see if I can show you this. Can you guys see that?
Oh yeah.
Oh,
Fractured,
snapped. Yeah.
snapped it
Yeah.
Wow.
while it was
It like
inside.
sheared off.
It's
Yeah.
sheared
Yeah.
off. You see,
Yeah.
and that's a discussion I think we need to have more of. Is what are we doing occlusally? What are we
Right.
doing with the implant when we restore? So that's a little teaser. So
Yes.
Doc, whenever you have an opportunity, come back. You know, this is how we do it. Whenever you have an
Yes.
opportunity to come back, let's talk about the next phase of dental implantology, which is basically the knowledge to restore the implants properly. You know, we did the
Absolutely.
surgical part. Let's talk about the restoration part of it, and how you went about learning that, and what you find to be the most important educational guides, or even mentorship, or whatever, that led you to, you know, having something that could last 20, 30 years.
Right.
Yeah,
You know?
and give us your information on your classes and how
Yes,
people can look that up and get a hold of you and
please.
uh,
Yeah,
so
so our website is teachmeimplants.org. And we usually put on about 2 to 3 courses a year. And we have a intro course, a PRF course, and a sinus augmentation course. And then I do continued one-on-one learning with doctors. So once they've taken all my courses, I'll come to their office and usually guide them. They'll come watch me for a sinus lift, and I'll guide them on one of their patients through a sinus lift. And I've had a couple of doctors successfully make that transition to, becoming very comfortable or competent and comfortable with some of the more advanced procedures that we do. But let me ask you guys a question real quick.
Yeah.
When is this airing?
It's actually we're gonna try to put it on really soon. I want to
Okay.
say within like another day or two. So
Okay.
today's the 16th, so within another day or two, we'll put it up there for you.
I asked that, and I didn't want to bring this up until the end because one of the things that I've always wanted to do was to complete a residency program, right?
Okay.
Just that was the goal initially that I had. I had to put it off because of family responsibilities. But in
Yeah.
the last couple years, I've taken the steps to doing that. So I will be starting at OHSU's Perio program on June 28th.
nice.
Okay.
Awesome.
And
Awesome.
the reason I'm concerned about when this is airing, so I haven't told my staff that I'm selling the offices yet.
Okay.
Oh,
You know we're still
surprise!
recording, right?
Surprise!
So you know we're recording.
Right.
So
But
I mean,
no. It's everything is closing within the next week or so. So I'm gonna have to tell them this week anyway. But I want to wait till the end in case any of them got curious. I doubt that the staff will sit through a whole hour of us just talking
talking.
implants and shit. Right?
Yeah.
So,
Oh,
but
that's amazing.
hopefully,
That's
hopefully when we
amazing.
do this again, I'll have some more exciting stories about my
I mean, this is,
transition and all
That's
that.
awesome.
Yeah.
welcome to the brotherhood. That's what I'm going to start off with, right? Especially us being the older people and Kyle being the young guy.
Right.
Maybe with a few more years of knowledge, he might join us. We don't know.
Right.
We don't know.
Right.
You know, but no, this is awesome. It's like great news. Congratulations on that for
Thank you.
sure. You know what I
Thank you.
mean? And
Appreciate that.
all the best. Honestly, we think that
Thank you.
this. I love this. I thought this was a really great conversation. I think this
Oh
is
yeah.
something that a lot of pre-dental and dental, everybody wants to. They want to hear it, right? And I
Yeah.
truly believe that you don't have to go the specialty route in order to become specially trained in a certain field. Implantology being the one here,
Right.
So I do believe that education and just continuous learning. I mean, Kyle he's got his master's. It just needs you just need to continue to learn. And CEs are not
Absolutely.
they're not a curse word. You know what I mean?
Right.
Like CEs are not a curse word, and I feel like
No.
everybody treats it that way.
Yep.
And that goes for GPs and specialists.
Yeah.
It's a
Yep.
learning is a lifelong journey. I mean, none of us are ever going to feel like there's nothing left to learn, which is why I was as comfortable as I was going into a residency program, is because the more I've learned, the more I've realized, holy crap, there's a shit ton of stuff out there that I need to get my hands on before I leave this world. You know what I mean? As far as knowledge goes. So yeah, absolutely.
Awesome. Congratulations. Thank you, Dr. Horton. We definitely appreciate you.
Appreciate you guys, man.
Instagram. Hit us up with your Instagram so people can follow you on that.
Yes, Teach Me Implants is my Instagram. It's my professional page. So you'll see cases, you'll see pictures. I do some humorous stuff, and I do some.
He talked to the tooth fairy. One of them I saw. He
The
talked to the
tooth
tooth
fairy.
fairy. Yes, I was like, all right. You know, what I mean? The only thing I was
Hey,
hoping for was for you to dress up like the tooth fairy, but that was another story.
listen.
You know,
If it gets me nominated for an Emmy, I'll do it. You know?
only the Rock can do that. You
Right,
know,
right.
that's awesome. No, but it's a great follow. I love going on your page and just kind of watching all the stuff that you're doing. It's really
I
interesting. If
appreciate
any
that, man.
dental student or any dentist wants to really kind of see what the level of excellence looks like, you gotta follow that page and just go. It's fun
Thank
just to
you.
even watch because it's just enjoyable just to watch other people's surgeries because that
It
can
is.
get me to go. Okay, I need to step up my game. You know, I need to step up my
Right,
game.
right.
So I'm good with that. You know what I mean? But thank you guys. Really appreciate this as always. It's
thank
always
you
great
so
Thank
to
much.
come
you.
back on the
This
podcast and
is
talk.
fun. Really
Oh
fun.
man, appreciate you, man. Thank you.